going to take a little bit for it to download. If you would just afford me 2 minutes. I just want to give an op-ed on all the talks we have had this morning. The first one was for the Watchman device, left atrial appendage occlusion. I think it's a very beneficial technology. We use it extensively. I would say up to 10% of our patients with stroke go for Watchman device placement. I think in this day and age when you can have a more durable treatment for AFib-related stroke without the anticoagulation, I think that's the way to go. The second one was the PFO closure. I remain a bit of a skeptic on that front. It's not that it's not a cause for stroke. It definitely is. I think it's the problem has been magnified several times, several-fold, and PFO has been made of a much bigger monster than it really is. So I think we have to be very mindful, very careful in patient selection. We can certainly discuss this at the end of this session as to what my thoughts are on that. And implantable loop recorder, I really like the question by Abhay back there who mentioned Apple Watch for this. So I'll tell you that I work at a fairly large comprehensive stroke center. We treat more than 2,000 strokes a year at our place, and we have a very robust, very sort of academically inclined EP department, and they refer patients for for Apple Watches a lot nowadays. So even they have kind of started to believe in the power of Apple Watch. The problem with the implant is that it's an implant, and more often than I would say 99.9% of the time, nobody explants it. So once you have it, you have it. Now you're walking around with a dead piece of technology in your chest after 2 years. So is that really needed? I think it's very effective. In fact, we have a whole protocol about implantable loop recorders for patients who come in with cryptogenic stroke, and they are sort of almost reflexively referred for implantable loop recorders. But again, you have to be mindful. You have to have a cardiology colleague, either a general cardiologist or an EP cardiologist, who is on the same wavelength as you in terms of do only what's necessary and don't just do it just because you can. I think the one piece I heard was, the insurance pays for this, so let's just get it. I think that's just a very silly way of looking at it. Just because insurance pays for it, so what? Should we get all surgeries done possibly? Possibly, probably not. So anyways, sorry, that was a bit of my op-ed on these things. The disclosure, I am a consultant for Stryker. There are other commercial relationships which are not relevant to this presentation. There's only one slide that mentions the Stryker device, so take that with a grain of salt. I'm hoping that we can review the indications for mechanical thrombectomy or surgical management of stroke. We can understand what is the evidence behind it and evaluate the latest advances in how we have expanded the indication for thrombectomy over the last several years. And that's an interesting journey that I hope I can go through with you guys. This is the PFO. I'm sure this has been shown, but since I had it, I figured I'll put it up. This is a PFO showing migration of a clot from the right atrium to the left atrium. So PFO definitely does exist, and it is a cause of stroke, but much less so than we think. This is a left atrial appendage clot, and so AFib is a much more common and much more prevalent cause of stroke. A lot of people make statistical mistakes, inference mistakes. We have a talk this afternoon on how to read a clinical paper. So if you think your statistics is a little bit weak, please do come join us for that. Okay, so I'll start out with this case. He's a 73-year-old gentleman who, history of AFib, was on Xarelto, needed a knee arthroplasty. Xarelto was stopped 1 week prior to his knee surgery, and then for some reason, somebody dropped the ball and Xarelto was not resumed 2 weeks post knee arthroplasty. So you can already see there's a problem here, right? Xarelto should not have been stopped 1 week in advance. All clinical guidelines say you need 48 hours of discontinuation prior to any major surgery. For minor surgeries, we don't even stop Xarelto. So this gentleman presented with left hemiplegia, sensory neglect, gaze deviation, and a facial droop and dysarthria. NIH stroke scale for the non-neuro folks in the audience, it is a measure of how severe the stroke is. The higher the number, the more severe the stroke. So NIH stroke scale was 17, which is moderately high number, just for reference. So this gentleman, I'm hoping I can point the laser here. No, it doesn't work here. So maybe you can see my cursor. This is an image of the right internal carotid artery with intracranial circulation. The blood vessel that my cursor is at is the ICA. And if you can follow my cursor, this is the middle cerebral artery, and you can see an abrupt cutoff or a truncation of a blood vessel right there. That's where the clot was. That's what was given. You can't see it. I'm sorry. So I don't think this is reflective enough, even though it works. Yeah, it's not the. It works. Yeah. Right there is a cutoff. You can see there's a vessel cutoff there. There's an abrupt truncation of the vessel, which is causing patient's symptoms. So we go in and we remove the clot. You can see, compare this to that. All of this is now visible. Shukran. All of this is now visible. You can see this clot has been removed. All of this brain has been, which was previously not perfused, is now being perfused. And this is the clot we retrieve from the brain. Not very large. It's only a few millimeters in length, maybe 8, maybe 10 millimeters in length, but it can cause a significant amount of damage and disability if not treated. This gentleman did fairly well. NIH stroke scale reduced to 2, which is pretty mild. And he was discharged to rehab, not because he had much of a stroke symptom that needed rehab, but he was still having a lot of knee pain, which had not been addressed. So that's why he went to rehab, is not because of his knee arthroplasty. All right, so let's see if we can play this video. I'll just so the audience here has some understanding of what's going on. Let's see if I can play it. It may or may not work. Okay, that's not working. Let's see if this video works here.
Paralysis, loss of speech, or dizziness.
So this is just
to
an animation
blood flow to the brain, the physician may use a retrieval device such as the Trillium retriever, a stent retriever that may reduce disability in patients experiencing ischemic
I'll kind of
stroke.
forward it and get through it
Called
quickly.
the femoral artery.
We usually use transfemoral access, but sometimes we do use radial access, or a transcarotid access will go directly into the carotid to remove, and there are different indications for it. I won't bore you with too much detail, but I just want to, for the audience to get just a general sense of how these things work. So this is this device being deployed within the thrombus itself, and the idea is that it will mechanically ensnare the clot and engage the clot, and when you retrieve it, it will drag the clot back with it. So this is under fluoroscopy, and you retrieve the clot, and you do, arrest flow and or reverse flow to allow new emboli from forming. And once you have done that, you will just pull the device back. So this is a reversal of flow, and the device is being pulled back. All right, so this is out. So let's get to the next slide. Okay. So I just wanted to give you a flavor of how this thing works. Can you hear me okay? No, it's not working. This is working. Okay. So now that you have a sense of how it works, I just want to go over the indication and the clinical data for it. So, I think Aamir mentioned when he introduced me, we didn't really have a whole lot of options for stroke, right? Up until 20 years ago, stroke was diagnosed and adios. That's what they used to say, right? You have a stroke. Yes, you have a stroke. We know it. We have confirmed it. Good luck with you. Nothing else we could offer. All that we could do at the time was antiplatelets, perhaps aspirin for secondary stroke risk reduction, and that's about it. And then intravenous TPA, alteplase got approved in 1995, and all we could do was give TPA. TPA was effective, but mostly effective in small vessel strokes. For large vessel strokes, and I'll come to it in a second, what it means to call something a large vessel stroke. It was not effective. If you have a clot more than 8 millimeters, the TPA was not effective at all. It will not melt the clot. It's just too much of a clot burden for the TPA to tackle. So people said, okay, well, large vessel is a very different kind of disease. It's significantly debilitating, a lot of morbidity, a lot of mortality associated with it. What can we do? Can we do something more than just TPA? So some very smart people had the idea, why don't we give TPA directly into the clot? And people did that. Had a lot of complications, a lot of hemorrhagic sequelae, and it didn't work as well. So that was kind of abandoned. And those studies, as this slide says, PROACT, where we used to inject pro-urokinase, this is before my medical career, and then MELT and IMS was a TPA plus thrombectomy trial, which I was around for IMS 3 onwards. So the IA thrombolysis rather did not work as well as we thought it was going to work. So we said, okay, why don't we, instead of thrombolysis, we do a thrombectomy, meaning mechanically retrieve the clot somehow. And we had many different ideas of how you could do that. And we had some retrieval devices, some intravascular ultrasonic agitators, thrombolytic agents, and so on and so forth. And most of these trials were negative, and there was a reason for it. I won't delve into it too much, but we didn't have the right tools for this kind of thing. We didn't have the right protocols, the right paradigms. We didn't get to the clot quick enough. So all of these trials just kept coming back negative as through, thrombectomy is not going to work. Until the trials that started coming out in 2015 and onwards, so it's been about 10 years, the first trial that was of its kind that was randomized and was positive was MR Clean, also popularly known as Mr. Clean. It was a Dutch trial that was done, and it randomized patients to thrombectomy versus medical management. As you can imagine, nowadays, that's a very difficult thing to do, to randomize somebody with stroke to medical management arm. Nobody would do it in a good conscience because we know it works. But back in the day, we didn't know. And people were randomized to do nothing, just medical management, or undergo thrombectomy, and it showed significant improvement in recanalization as well as the patient outcomes, and I'll share the data with you in just a second. Along with that, multiple other trials around the same time, from early 2015 to early 2016, multiple studies came out showing that the thrombectomy worked. All right, this is the recanalization rate. I won't go into too much detail because I don't want it to make this a very dense talk. Mr. Clean was the first one, and then SCAPE, SWIFT Prime, Extend IA. They all had different criteria for enrolling the patients. What kind of patients you enroll, what time window you enroll in, what parametric imaging you had, so on and so forth, and we'll go over that in just a second. But all of them were different. But what they did show is that the recanalization rate, to open up the blood vessel, you could do it very reliably and with a high degree of confidence and high degree of efficacy. So these were the devices we used to use before. This is something called a Mercy retriever. It's obsolete now. Nobody uses it. We did use it back in my early part of training. And the idea was that you would ensnare the clot and pull it out. It only worked 50% of the time, so it was just a coin toss. Then we had these kind of devices. This is called a stent retriever. This particular one is from Stryker, but they're one from every company nowadays. This is a portmanteau of stent and a retriever, so it's called a stent retriever. They're fairly effective devices. This is how they work. And nowadays, more and more people are utilizing aspiration thrombectomy. So you just get a large bore catheter right next to the clot, and you just vacuum the clot out, and that works very effectively. That's my personal favorite. So how do these things compare to medical management? So if you look at the good outcomes, and I should give a bit of an explanation here, what good outcome MRS 0 to 2, at the top of the slide if you would see. MRS stands for Modified Rankin Scale and how functional somebody is. 0 means no deficits, 2 means they're able to ambulate independently without any assistive device, without a cane, without a walker, and 5 means that they're bedbound, 6 means they're dead. Okay. So MRS 0 to 2 is we considered a good outcome, meaning they're able to ambulate after a stroke without an assistive device. I mean, there are other nuances to it, but that's the major one. So you can see there's a significant difference, and these are absolute risk reductions, not relative risk reduction. Again, please do come to the How to Read a Scientific Paper talk this afternoon. These are absolute risk reductions, and you can see there's significant absolute risk reductions between the two arms. Okay, so this is the first time we are seeing a significant improvement in patient population after they had undergone a thrombectomy. Okay, so very good results, but why? Why are they different? There's one that says, there's a difference of 24% if you look at MR clean, but if there's a 31% if you look at extend IA. Why are there such differences? Why? Because the selection criteria was different. Okay, what are the selection criteria then? All right, this is something we call aspect score. This is Alberta Stroke Program early CT score that you look at, just a CT scan, which is available at every hospital in the US and Canada. You look at the CT scan and try to figure out how much of a damage has already been done and how much damage could occur if this goes untreated. And you would select the patient based on that. So if you select the patient who are most, who stand to gain the most from the thrombectomy, of course your difference between the treated and untreated arm is going to be very different. But if you take all comers without any discrimination, without any distinction of who's a good candidate, who's a bad candidate, that was Mr. Clean. That was all comers. Anybody who had a larger cell stroke within 6 hours, you took them to the OR, you took the clot out, and the difference was 24%. Still really, really good. But if you did some kind of imaging to discriminate between the two, good candidates versus bad candidates, those, that distinction between the two could go as high as 40% absolute risk reduction in some studies. Okay, so that's one way of doing it. The other way of doing it, we were doing CT perfusions. Don't want to bore you with the details of it, but you can see the color maps on your right. The pink areas are where the damage is already happened, or it's most likely an irreversible damage, meaning this area is not coming back. Onto the right, there's a green area which shows that there is the brain at risk. This will die, or this will get irreversibly damaged if we don't do anything about it. So you can see the damage is pretty small, the potential damage is pretty high. This is a very good candidate to undergo a thrombectomy. Okay? Here you can see the pink area almost matches the green area. This is not a good patient to go for because the damage has already occurred. You're not going to help them as much, or at least what we thought back then, about 10, 12 years ago, that's what we thought. But the reality is a little bit different. Okay, so IA thrombolysis happened, negative trials happened, pivotal trials happened. Then we said, okay, that was up to 6 hours. But what happens to patients who are coming after 6 hours? A lot of these patients are coming way much after 6 hours, 12 hours, 18 hours. And can we offer them something? Can we extend the window of treatment for these patients beyond 6 hours? And so multiple trials were done, Dawn, Diffuse 3 amongst other, which were labeled as late window trials. So up to 24 hours, we were able to offer thrombectomies. Of course, there'd be some selection criteria based on imaging and who's a good candidate. And if they were a good candidate, even up to 24 hours, we'll take the patient. All right, so here's the case number 2. 84-year-old gentleman with history of palpitations. Nobody bothered to interrogate why he had palpitations, all right? Most likely AFib. And he was not on anticoagulation. His last known normal was 16 hours ago. He lives by himself, he had a stroke, he laid on the floor for several hours, then some family member found him and brought him to the hospital. Right hemiplegia, global aphasia, left gaze deviation, very high NIH stroke scale, meaning it's a very severe stroke that this gentleman is suffering. He comes in, this is what we see. This is what we call a pseudo-occlusive sign of the carotid artery. This is the internal carotid artery, and you can see this haziness here, that's the clot. And there's much more clot up ahead in the brain, but you're not seeing that because there's lack of anterograde flow. The flow is not there, so you don't really see much. So we go in, we find a whole bunch of clot. This is now the internal carotid artery in the head, in the intracranial segment, and it's completely occluded, and there's a significant amount of thrombus burden. All of this is clot here. Okay. So went in, opened it up. Now looks a little bit better because we removed a whole bunch of clot, but still not completely open. There's still occlusion of this middle cerebral artery, and you can see this clot blood interface right there. Which, we go in, remove all of that. Huge amount of clot burden removed. There's a clot torqued at the catheter. This is an aspiration catheter we use, and large amount of clots were retrieved from this gentleman's head. And he did, for all things considered, remarkably well. His 24-hour anisotropic scale dropped to 6. He was able to ambulate with some assist, and he was discharged to rehab post-stroke day 3. Another good outcome. All right, so we extended the window. What's next? What about large cores? I told you, we showed you a picture earlier on where the pink and the greens were matched, right? Those patients have very poor outcomes, right? They have malignant edema of the brain. They require surgical decompression. They're hemiplegic, require trach, require PEG. They're in a nursing home. They have a very miserable lives for the rest of, 6 months, a year, 2 years, whatever they're going to live, and it's just not going to end well for them. So can we do something for them? The answer is yes, we can. Not always, but in many cases we can. Here's that example again. Large area of pink and green are almost matched, which is what we call a matched CTP. And so the question was, when you have a small core, when you have a small pink area and a large green area, yes, those patients, we can take it from a bad outcome to a good outcome. But a large core, could we take them from a bad to better outcome, a little bit better, maybe a good outcome? All right, you're not going to make them completely better, but can you help them out enough to have some meaningful life, some quality of life? And could you avoid a hemicraniectomy? Again, I won't go through it. There's multiple studies done on that topic. Rescue Japan, Angel's Aspect, Tesla, we were part of this trial. Tension, we were part of this trial as well. Select 2. Anyways, long story short, multiple trials done with slight variation on patient population, patient selection criteria, the type of intervention offered, and so on and so forth. But the bottom line was the same. Patients who had large core on imaging and underwent surgical management, did they have a good outcome or not? And the answer was yes. They have had a significantly better outcome compared to the control arm. Okay. In some instances, up to 30% higher outcome of good outcome as compared to if you didn't do anything and just did medical management only. All right. So we have gone from not being able to do anything, just aspirin, now then give TPA, then failed surgical trials, then good surgical trials, then expansion of time window to large core trials. Now what? Okay. Now we have medium and small vessel occlusion. Let me just kind of go over this before I go there. There is a picture I want to show you real quick. When we say large vessel occlusions, and I'm going to point it here in a second, we're talking about more proximal, more closer up vessels in the brain. We're not talking about very distal, very far out vessels in the brain. And I'll point out what we mean by proximal vessels. This is a picture of anterior circulation. This is the internal carotid artery, and this is the middle cerebral artery. This is the anterior cerebral artery. This area here we'll consider large vessel occlusion. This is posterior circulation. The very on top you see a red tube, a red vessel. That's basilar artery. That's also considered a large vessel. So those are large vessels. Everything else you see beside what I just pointed out is considered medium vessel or small vessel. Okay. So you can imagine how small these small vessels are. Many of these small vessels are 1 millimeter, which is the tip of a pencil. 2 millimeters, and M2s or some of the P2P ones are 2 millimeters, which is the tip of a crayon, and 5 millimeters is your carotid artery, which is the back of a standard pencil eraser. This is how small of these blood vessels we are talking about. So at this point, this is not just routine surgery, this is microsurgery. Okay, so we know that patients who came in with distal occlusions, clots which were pretty small and far out blood vessels were occluded, could they benefit from this? The answer was not known. People didn't offer it because these are higher surgical risk procedures. As the blood vessel, as you go farther and farther up in the brain, becomes thinner and thinner and more prone to trauma, surgical trauma. In fact, if there are neurosurgery colleagues here, when you look at the brain under microscope, intraoperatively, you can actually, some of these blood vessels are so thin you can actually see the blood flow inside. They're paper thin. Okay, so now you're trying to shove up all these things in there and remove the clot. you're going to cause trauma. You may not be successful because the hemodynamic changes at such a small scale. Many things that can happen that does not lend such small vessels to surgical intervention. Nonetheless, these patients had pretty bad outcome. Even in the small vessel occlusion, they could have pretty bad outcomes. So the question is, could we then go in and intervene? Okay, so Aamir trial was done, didn't show any improvement. Escape-MEVA was done, no improvement. Distal, no improvement. Discount, I believe, was another one, no improvement. Then there was one trial done which was not a randomized trial, it's called imperative trial, and that shows some promise. And the change here was that we were not using stent retrievers, the little cage, the metal contraption I showed you, but we're using aspiration thrombectomy, and that seemed to help quite a bit in terms of reducing your morbidity of the procedure and the outcomes as well. So now there is a trial in the works, just got announced about 3 months ago, which is going to be prospective double-blinded randomized control trial, which is the gold standard when we talk about clinical evidence. So we are hoping that that is indeed going to be positive. We know by experience, anecdotally, that is going, these things help, and I'll show you a case where it helped tremendously. And we do routinely perform medium vessel occlusion or distal vessel occlusion thrombectomies for our patients. This is a young lady who was 32-year-old, was 5 days postpartum, came in with sudden onset of expressive aphasia, a mild facial droop and dysarthria, slurred speech, no limb weakness, okay? And our stroke scale was sort of medium, not very high, but not super low either, and our stroke scale of 8, all right? Here, hopefully you can see the blue circle here. That's a very far out distal. Up until now, what we had shown you is the clots either here or down here. This is all the way back up there. So that's a M3 level occlusion, okay? So you can see the catheter of my catheter's tip is at that point of occlusion. We remove the clot, the blood vessel is now open. That's the location. And this is the area that was not being perfused. That was the Broca's area, okay? Now it's getting perfused here. It's not truly Broca's area, but take my word for it, Broca's area is a little bit more inferior. But anywho, that was the area that was not getting perfused and getting much better perfusion now. This patient was discharged home 2 days later, and a stroke scale of 0. She had a hypercoagulable condition precipitated by her postpartum state. We had to treat her with anticoagulation for a short term. Okay, anterior cerebral artery occlusion, yet another. I'm just going to go through some slides very quickly to give a taste for, where the problems might be. You can see this is again considered a medium vessel occlusion, ACA. We pull the clot out, and you can see the comparable vessel on the other side, and it's open. Posterior cerebral artery occlusion. This is a gentleman I just did within a month, I think. This one was a young gentleman with a non-ischemic cardiomyopathy. He threw a clot into his PCA. The arrow is pointing to the left PCA, or left posterior cerebral artery, and we removed the clot. This gentleman also did pretty good. We have talked about anterior circulation mostly, ICA, MCA, ACA, so on and so forth. There's not a whole lot of evidence about basilar artery occlusion. Now, basilar artery occlusion, you might recall from your anatomy days, is an extremely important blood vessel in the brain. And occlusion of this blood vessel, if it's untreated, 90% mortality, probably more than 90% mortality. And there is no good scale to assess how severe the posterior circulation strokes are and how to measure the outcomes of your surgical intervention or medical intervention. So it's still a gray area within neurovascular field. We're working on it, but there isn't a whole lot. And compared to anterior circulation, there's not a whole lot of research on posterior circulation. There is a basic study which was positive for basilar artery thrombectomy. There's a Bausch study, it was a Chinese study that was also positive for the study. Here's a gentleman, this is a lady actually, sorry. It's a lady with a 48-year-old, fairly young, history of lupus, multiple psychiatric conditions, had ischemic cardiomyopathy, pretty young age for having ischemic cardiomyopathy with poor LV function. She was admitted for shortness of breath. She was in-house, in inpatient setting, and had a sudden onset of dysarthria and blurred vision. Stroke alert was activated. She was moved to the ICU. By the time I got to see her, she had progressed from just dysarthria and blurred vision to right hemiplegia, and she was not looking good, to just depressed sensorium. Took her, had a occlusion of the basilar artery. The white arrow is pointing to the basilar artery. It's the top of the basilar syndrome. And we open it up. More astute observers will notice there are some other things wrong with it. There are other small branches occluded. We tried removing the clots. We couldn't. But this patient did not do well. She had massive cerebellar stroke, brainstem, pontine, and midbrain strokes, and she did not do well. She actually ended up passing away because she remained comatose for two or 3 days after the procedure, and the family decided to withdraw care. So not a good outcome, despite everything that we could offer this lady. Okay, challenging situations. We're talking about, surgical management of stroke. What other things can we do? Okay, we talked about just sucking the clot out or pulling the clot out. What other kind of things you may encounter in an acute stroke situation if you're talking about surgical intervention? Intracranial atherosclerosis, it is less common in white, more common in blacks and people of Asian descent. If you work in a community where there's a lot of Laotian community, Cambodian, or Southeast Asian in general, significant amount of intracranial athero. Even South Asian population, Desi population, has a huge amount of intracranial athero that you would encounter if you were to treat these kind of patients. We had a 42-year-old lady, young lady. She had a history of end-stage renal disease. Don't know exactly why. She was on transplant list, and she presented with sudden onset of Broca's aphasia, right hemiplegia, left gaze deviation, NI stroke scale fairly high of 23. This is a pretty severe stroke. And she comes in, and you can see that there is this occlusion of a blood vessel where the white arrow is pointing. That's a proximal M2, okay? We tried going in, sucking the clot out with the aspiration, putting a thrombectomy device, stent retriever device. Nothing happened. It would just open up for a few seconds and shut back down. That's a sign that there's an underlying intracranial athero. All we had to offer at that point was acute stenting of this vessel. We placed a stent in there. Here's the view. You can see the two ends of the stent inside the blood vessel. And in response to that, the blood vessel is indeed open. She had a pretty good outcome. At 6 months post, she was functionally independent, had a very mild aphasia, very mild word-finding difficulty. If you had met her on the street, you wouldn't even know that she ever had a stroke. But because she's my patient, when I see her, I can tell that she is having a mild difficulty talking. She's functionally independent. She underwent renal transplant about 3 or 4 months after the fact, after her stroke. She's doing great. In fact, I just saw her this week in the office, and she's doing very well. Tandem occlusions. This is when you get a carotid disease, more than 70% carotid stenosis and or carotid occlusion, and you also have a clot. This is not an embolic stroke. This is a, artery-to-artery embolism. This is not a cardioembolic stroke, I should say. This is an artery-to-artery embolism or atherothrombotic stroke. So this is carotid artery here. I'll just kind of point it here. This is a common carotid artery, external carotid artery. This is the internal carotid artery, and you can see there's a significant amount of disease and thrombus here, and there's just a slight amount of contrast you see post, and then nothing intracranially. There's no flow intracranial. This is functionally occluded blood vessel. So we had to go in. The first thing we had to do was tackle the carotid, right? So first thing you do is just go ahead and put a stent in there, all right? Because otherwise you have no access to intracranial compartments. So you put a stent in there, open this up, then you get in, okay, so after we have done that, then we encounter more clots, right? Where the arrow is pointing, they're just ICA full of clots, okay? So then we had to tackle this, take those clots out. Then you go up in the brain, and then you have to tackle with this. You can see where the arrow is, there's a truncation or cutoff of the blood vessel. Then you have to tackle with this. And then you finally open that up, and this gentleman had a decent outcome. Not a great outcome, but a decent outcome. He went to rehab, and he's walking with a cane or a walker. Okay, so we don't know what to do with these kind of lesions, the tandem occlusions. There's research going on that. Picasso was published. It is beneficial to do these. We know that when you operate on these lesions, patients do well. There is, I'll just hurry up here. There is another trial going on right now, which is looking at stenting or just angioplasty initially and not putting a stent, and also what kind of antiplatelet agents when you use at the time of surgical management, and see how the outcomes are. So that study is still going on. We've talked about good outcomes. Not everything is good. There are complications associated with that as well. Embolization of the new territory can happen. Arterial perforation can happen. Sometimes they're okay, self-limited. Sometimes they can be disastrous. Dissections can happen, especially if there's a lot of tortuosity in the neck, in the carotids. Vasospasms can happen. I will kind of hurry up. This is an example of subarachnoid hemorrhage from a wire perforation or a vessel dissection. In this case, it is fairly small and clinically irrelevant, but it can become a disastrous situation where patients can have, or you can have a reperfusion injury where you remove the clot and it's already a fairly damaged brain, and they have a pretty large intracranial hemorrhage after you remove the clot. Iatrogenic dissections, I mentioned, especially if you have severe tortuosity of the carotid. We keep the blood pressures low after the thrombectomy. We put them in the ICU at least for 24 to 48 hours. Watch for any swelling, any need for surgical decompression of the brain if needed, and avoid fevers. We aggressively manage fevers because it has been shown that fevers and severe hyperglycemia can really ruin a good. You work so hard to get this clot out, and then now the patient is not doing well because of other complications. Okay, so I want to talk about this as a just parting message. These are the number needed to treat to save one patient or give one patient an independent life after the stroke. After a large vessel occlusion, this is number needed to treat one patient. So if you look at the inclusion criteria for Mr. Clean, you need to treat 7 patients to get one patient back to their independent lifestyle. If you look at the Extend IA, you need to treat only 3 patients to get them back to their functional independence. Compare that with coronary artery stenting for acute STEMIs. All right, that number is 17. You need to treat 17 people to have a good outcome in acute STEMIs. But for acute stroke or large vessel stroke and anti-circulation, that number could be between 3 or 7. I will leave you with this. This is, again, same information in a different format. I wanted to draw your attention to these 2 things. The first, this yellow bar onto your left is goal-directed therapy for sepsis. And the one after that is PCI for high-risk ST deviation myocardial infarction. The thrombectomy for stroke is here. This group here. All right, so you can see that it is significantly, vastly superior to other commonly treated conditions, yet it is not available to all of our patients. So, it's very important that the communities we serve, the hospitals we work at, the programs we direct and lead, please make sure that your hospitals have these capacities and capabilities to serve your patients properly, because we can do a lot more for stroke patients than we could or can do for the PCI, for the STEMI patients. Okay, I'll leave you with this. I'll take any questions that you might have. Yeah.
Very nice talk. I really enjoyed it, and the way you presented it based on the progression of trials that have come across since the 90s. So thank you for that.
Shukran.
When I see these post-thrombectomy patients, usually they either achieve a TICI 2B or a TICI 2A. Not many times do I see a TICI 3 flow come through. Would you say that that is a multifactorial reasons for that based on either the clot characteristics, the location, the operator, the device itself? So where would you put more weight as to why the clot was not completely able to be retrieved at that point? Number one. And number two, whether the patient receiving systemic thrombolytics prior to undergoing thrombectomy helps you remove the clot any better?
Well, shukran. The excellent questions, both of them. I'll tackle the second question first. Whether receiving thrombolytic before, meaning TPA, before we do a thrombectomy, does it help or not? The jury is still out on that. There were initial trials that came out that said, yes, it actually is helpful. Having received IVTPA beforehand improved your chances of achieving recanalization. But nowadays, the quickness, the workflow processes are so good that people are advocating, skipping IVTPA and just going for thrombectomy, because you can do a lot more improvement, or you get a lot more improvement by just going directly to thrombectomy rather than wasting time with IVTPA. So it goes both ways. At our institution, if the patient qualifies for IVTPA, we give TPA regardless. Whether it helps us or not, it's a very minor issue, because using the right techniques, you can still achieve a very large, or very high rather, recanalization rate. You could be successful anywhere from 85 to 90% of the time in removing the clot. So that was the I hope I answered your question there. The first question you had, what is it dependent on of how good of a recanalization, of how well are you able to open up the blood vessel? And you mentioned these scores called TICI scores, which are kind of derived from TIMI scores, which are thrombolysis and myocardial infarction, which is how well has the blood vessel been opened up after it was occluded. So from TIMI we have derived TICI, although there are some variations on the scale. What you had referred to as 2B is is the more than 50% of this territory been opened up? That's TICI 2B. TICI 2 is less than 50%, and TICI 3 is 100%. There is a new one in there is like TICI C, which is only a minor distal vessel occlusion. So to answer your question directly, what are the factors which sort of dictate how well of a recanalization you're going to rate? Clot characteristics used to be thought to be a big contributing factor, but not so much, because now we have clot agnostic devices which can pretty much take any clot out. I think certainly the anatomy matters quite a bit. The operator experience matters quite a bit too, and what technique you use. So I think all of those things, but I think a lot of these operators are, because it's a high volume procedure, a lot of people are getting pretty good at it nowadays. I hope I answered your question. Yeah.
I have a question. In your large core strokes, maybe like 10 days or 6 days back, what is the risk of secondary hemorrhage after retrieval of the clot? Because the large stroke and recirculation perfusion, does it increase risk of bleeding?
Yes, absolutely. So we do see that when you look at the large core stroke trials, the risk of hemorrhage within the stroke bed is significantly higher with surgical treatment versus no surgical treatment. However, I'll say this: dead brain is dead brain. Whether it's open and dead or closed and dead, it doesn't really matter. So unless there's an expansion of hemorrhage, it doesn't really matter, because it was dead to begin with. So if you open it up and now has bleeding within the stroke bed, so what?
A second question is I've been practicing for 42 years and I've been already retired, but in those days there was the AC-IC bypass, and I knew it was not very successful. What is the status of that at this point for M2 strokes? Yeah, so I would qualify that we don't use AC-IC bypass for acute strokes. For chronic ICA occlusions or chronic MCA occlusions, AC-IC bypass is still an option. The selection criteria has significantly been tightened over the years. As long as I've been practicing, it's a very narrow channel of patients who would benefit from AC-IC bypass, but when correctly selected, it is a very effective treatment, and we routinely perform AC-IC bypasses on patients who who have chronic occlusions and have flow issues, perfusion issues to the brain. Up to 24 hours. Up to 24 hours after a stroke, we can offer thrombectomy in a variety of scenarios and cases. After stroke, within 24 hours. So up to 24 hours, we can intervene. After 24 hours, the jury is out on that. I just saw it come through my feed a couple of days ago that there are trials being proposed for up to 72 hours. We will see how that goes, but right now it's up to 24 hours. Sorry, Bhai, you had a question over there.
Very quickly, just to clarify your last comments of individual education, is there low or slow adoption for thrombectomy? Why are you requesting more?
Yes, so in large cities and large hospitals, it's a fairly standard practice. But for smaller towns and smaller hospitals, this is not routinely done. Okay, neurologists are not, still kind of behind the times somewhat. ED physicians may not be aware of the options, or simply they don't have access to it. We serve a 3-county area, and we have patients flying in from 100 miles away because there's just nothing in those counties at all. So it is still an issue. It has improved significantly over the years, but there is still a significant gap of where we need to be.
What do you think will fix that?
Government funding is one, and I think the physician education is another one.
Dr. Badruddin, very nice talk. Just can you summarize your use of stenting, intracerebral artery stenting? I mean, it sounds like mainly your first goal is to do thrombectomy and leave it alone. But are there any instances where you will have to potentially consider putting in a stent after you've done thrombectomy?
Yeah, the younger the patient, the more aggressive I usually am. I think that's the short answer of it. In my younger days, I used to be fairly aggressive on intracranial stenting. But research has shown that it's not as durable as we think it is. The surgical management of intracranial athero is still not panned out in terms of surgical management. It's still medical management is preferred. But if it's symptomatic, if it's flow dependent, if it's pressure dependent, then I have no option but to treat, because if I don't do anything, patient's going to stroke. So we do it, save their brain today, and we'll see what happens in 2 years. That's a 2-year later question. So I will do it in younger patients more aggressively, although 2 weeks ago we just stented a lady, 84 years old, who was significantly pressor dependent. She was on norepi and vasopressin for a couple of days, and every time her blood pressure would drop below a certain threshold, she would become very symptomatic. So we had to take her urgently, not emergently, but urgently we had to take her and put a stent in the MCA. Both. We do both, depending on the tapering of the blood vessel. If it's very tapered blood vessel, we do a self-expanding, but if it's a very uniform caliber, then we'll just do a balloon-mounted stent. G.
So for coronaries, there's a time aspect from presentation to revascularization. I know you said for strokes there's a 24-hour window. Is there a time constraint in how soon from a patient presentation to revascularization?
Yeah, I mean, there are mandates from Joint Commission as to how quickly, that's 90 minutes. So from patient entering the ER door to us getting up to the clot is 90 minutes. That's the mandate. Of course, it doesn't always happen that way, because weekends, nights, you might fall behind what's needed. But you should be, groin puncture should be done within 60 minutes, and you should have removed the clot within 90 minutes. That's the Joint Commission mandate.
So I mean, for coronaries, for patients presenting to sites that don't have primary PCI availability, it's not uncommon to sometimes give lytics and transfer, or sometimes get primary transfers. What is the practice in neurology? Same
thing. We call it drip and ship. So you would start the IV. Well, in the days when we used to use alteplase, we will start the drip and transfer the patient over to a comprehensive stroke center. Nowadays, it's tenecteplase we give, and it's just a single bolus, not a drip. So anyways, we will give the bolus at the spoke hospital and transfer them to hub. So that's a fairly routine practice at our program and programs across the country. G.
People asking questions, please introduce yourself.
Sorry. Okay, so Dr. Ibrahim, neurologist. I think just to speak on a couple of points to also address the topic about, the access to patients. In Houston, we now have mobile stroke units as well. So these are designed people who are very good at identifying a stroke in a sort of like an EMS service type situation that have capabilities of doing CTAs inside the EMS service. They can actually give TNK or alteplase. So this has significantly reduced the amount of time in terms of how we treat stroke patients. And the other comment that the other PI made about doing TNK or alteplase and thrombectomy, all the trials that I have seen, and you can speak on it more so, has shown that TNK or alteplase with thrombectomy is still better than just thrombectomy alone. I know the numbers are, very similar in nature, but I think that points to the fact that there's still a role for TNK in stroke management, given that access is not so available to patients to get thrombectomy, and it sort of maybe helps push the time window a little bit and offers some time to at least transfer a patient from a hospital setting that doesn't have these capabilities to a more tertiary center.
Yeah, no, great comments. I completely agree. We do not withhold TPA, tenecteplase or alteplase from our patients. If they qualify, we give it. Even though we know it's not going to help, we give it because there are still nuances to it that we don't understand. So we definitely would give it. As far as the mobile stroke unit is concerned, I'm a big fan of mobile stroke unit. I think it's a great marketing tool, but not a great clinical tool. But it helps. It helps quite a bit, raising awareness, and you can do things with it that you couldn't be able to do otherwise. We can talk after, but there's a German study that showed that having negative TPA door-to-needle times did not help in outcomes. So, but that's other discussion. Oh, shukran. Yeah.
Thank you, Aamir Bari, for the excellent talk. I'm Dr. Chandabai, working as a hospitalist with Baylor College. With M1, M2, and small vessel disease, I want to know what do you think? Based on the CT diffusion, or is it the NIH scale which makes the decision to go in for interventions?
Yes, certainly I think the clinical picture trumps everything else. So what does the patient come in with? All right, so if it's just, let's say, minor numbness on one side, on an 80-year-old lady, I'm not too excited about pulling out an M3 clot, right? But the example I showed here was a 42-year-old lady, I believe, who had a significant aphasia. I'm chasing that. So clinical scenario and clinical, who the patient is, trumps everything else. Pictures are pictures. The adage in medicine is treat the patient, not the pictures, right? So we treat the patients.
Because I've seen it go both ways. Sometimes we consult the neurointervention and say, okay, this is a small stroke, small vessel, nothing to do,
Yeah, that depends on what time of the day it is. Is it 2 in the morning or 2 in the afternoon, and how tired the neurointerventionalist is.
Thank you.
Shukran, everybody. Khuda Ta'ala, apna आका ने मौला मुनीम ने तारोज़ क़यामत उम्र ने तारोज़ क़यामत दराज़ करे. आमीन.